reason I'm here. Great. Should be live.
My first meeting is the 14th and 15th of November. Yeah, so it's just like 1,000 more like orientation packages and like filling out a ballot paperwork, and they're like, there's spare on blah blah blah. And like, so we are in the ceremony, and I was like, I don't know what either. I literally emailed back being like, I don't know what either of those things are, so you should probably tell me which one to do. It's like the secretary, and she's like, oh, here, let me explain it. Yeah, I'm just picturing like I did it a long time ago.
And she makes them swear on Bible, but it's like a Bible app. And they have an iPad, and every time she turns the person, it like switches the orientation, and they just keep like flipping it back and forth. That's exactly what I'm picturing.
That is probably how it would have gone, but I just that was doing.
You like download the Bible app. One thing is good for.
Yeah, so it's just like I'm getting started. They sent me like.
Hello, Nick Claire. Relax.
Very
Nice to meet you. So I am your back. So yeah, that's what I said. So what time are people?
They should be coming in over the next 15 minutes.
Okay. Perfect. Awesome. Yeah, whenever you guys are ready to go, feel free to line up. And I got two servers here. Her name is Maya and Clara. They'll be taking care of you guys, but I'm here the whole time. There's a phone over there. This is dial 0. I'll go to the front desk, and the front desk will wait you. I'll tell them to go and start doing coffee and tea pretty quickly. We serve it. They want us to put stuff on the table. Yeah, we do that. Okay. Yeah, no problem. Yeah, absolutely. No. We usually do that on our lunch events. Like if they're going straight to the meeting, and if the meeting is like a little bit sensitive, they don't want to be disturbed. Right? Yeah, so that's how we do that.
Because I see other things. We'll have a break on the
Yeah. Okay, no problem.
Are you Claire?
I am
Claire and Kari.
Oh, hi, Kari. Nice to meet you. Yeah. Everything's so That's great. I forgot that I forgot that I was supposed to be supporting the projector, so there was like a temporary moment of panic, but I got a projector. Thanks for all your help.
Oh, you're welcome anytime.
Okay, unlike the one with the dark black.
There's 3 people watching already. Go right here.
No.
I feel like I've been eating.
I was trying to say,
Yeah. I mean, we're moved in. Great. It's like so we were laying in the great. And are you past like are you over the hump of like hardcore mom? Okay. It's sitting in our garage right now. It's we were on this side of permission, and then we moved over to that side, like so our voices started being started being out, and our street was like, and so people were like, we were eating and we were talking about we were just running to this to me, we loved our house. We were lovely neighborhood. So we found a black box. And it's been awesome. Like, there's like a little rabbit that comes in like every day before our dinner. It's really funny because there's about 4 girls the same age. And they all have these pink like helmets and so they like line up and like the rug. Like being bad. It's so far and like really nice. And so like first thing oh, okay. Find out what's been going on with great. Soccer in my kids and this is like very first soccer. And because he was like they got their little jerseys and they're running around all night and get the ball and so right so he gets the ball and goes to other kids soccer and while they're just like and like yeah, they keep looking like on my head it's like yeah, no, I don't. Yeah. They're fun. Hey, how's it going? Good to see you. I guess you're here to Thanks, Larry. How's it going? Good. Oh, it's okay. Yeah. Oh, yeah. I got like my eyes are just kind of like dry and like I look like a devil, but I am. Just your time. That is so funny. Like, I have to stop seeing me. Yeah. It's wrong, but I don't want to like cry. Oh, that's hilarious. I was like saying, looking at time, seeing my eyes. Yeah. I wanted to make sure I had the most up to became wise. I have my USB nice. I have my there's like, I feel like, what did I do? I added like basically nothing, but
That's okay. I just figured I should get.
I also want to pull up my so I have to switch back and forth between screens for the next meter thing.
We're just live streaming right now, so which you can hear.
Oh,
Sorry, I was throwing blur.
It's already turned on.
Yeah, so just.
problem with this drive. Interesting.
Just continue without scanning.
That's a better choice.
I think it's fine.
Yeah.
Is that, yeah.
Okay. I'm just gonna save it to this box. Please I'm gonna say final presentation. Okay, perfect. Do you need to do anything else?
I was just gonna sign on to my I'll just sign on to my computer account on the internet, and then I can hopefully I won't crash everything by switching back and forth between. So then the audience can see the live results as they come in.
Yeah, give it a shot.
If it doesn't work, then I'll just abandon it.
I think that Sheely has an app where you can pull the audience with this album.
It's not an app; it's just a website. So all I need to do is switch between my presentation.
Does it have to be in Explorer?
No, I just saw that on the bar. I can close out of that. You prefer me to put it on?
Well, we just use Chrome for everything.
Oh, okay.
That's the only reason.
Oh, yeah, for sure.
I think what'll happen is she'll just switch between the presentation and the Mentimeter browser. Because it should screen. It's just screen
just mirrors
mirroring,
whatever's on
so
the
it's
screen.
whatever's on the screen is going to be what people see. So
This is.
yeah.
So there's
Oh, I wanted to extend my screen onto there so that I can have my speaker notes.
I printed out your speaker notes, but I don't think it's really possible for us to extend because all it does is screen mirror.
yeah.
Oh, you can't do the two desktop thing and
Yeah.
That's okay.
Yeah, it's just whatever's on that screen
Right.
is what's on.
Oh, I should have brought my laptop because my laptop can extend out. That's okay. That's fine. That'll be good.
I have this here for you, and it's got all of your speaker notes on the bottom. You can sit at whatever table that I have. I'm sitting here just to make life easy.
Okay.
I remember when I read that about 2 months ago. Oh, it's okay. I felt so bad. I was just like, anyways, I just have one of bad at using my No one has shot on my work. Like said that to like dinner with her friends.
No. She's great. Hi.
Like I'm not gonna cat, like I can't do it. Like no, I'm gonna do it. Like I made it and I'm gonna get it done. Like whatever next time.
I know. I have to like not really. Oh.
Thank you. I feel like you actually really that was my
No, that's. Oh yeah.
Who is that woman?
I did. I did. I'm rebellious. I'm also
Like, we haven't had
Sorry. Here, Shelly.
Hi everyone. I can't go louder. Hi everyone. I just wanted to encourage you while you're chatting to start helping yourself to the buffet. So over the next 15-20 minutes or so, grab a plate and start eating, and then we'll get presentations going after that. Thanks, guys.
Deciding if it's too cold.
Like, don't stop there.
Watch her. I'm sorry. Here, let me guide you. Let me help. I was not very I will. Hi. We've like barely met once. Yeah, I was like, now that I'm actually looking at it, you put us together. Yes. Your friend was there. Okay. And I was just rotating there with Casino. And then it wasn't until yeah, wait, so what were you doing? I was doing did you go back to that? No, I literally so do you. But you were presenting. Okay, so I got to you're in. Yes, I know. Oh, I know her very well. Oh, yeah. I don't know her like super well, but because I like. Yes, that's right. Yeah, so we're very close. But like, I just like really wanted to talk more to her. I was getting used to work with her. Yeah,
There is a spot. Please.
Yeah. Like I did that. Like it's a very long day. For my breakfast, so candy on there. I was like, she's like, yo, you can serve that when you're coming to me. Probably not even until 9. Like, let's be honest. So. Yeah. Oh, really? Haley, welcome back. Thank you, welcome back. Like, Yes. We just Claire, Josh also will be.
I bet I'm guessing would be live me.
I think we somehow.
I think
We also play Well, every house is that I didn't realize that. I didn't think Greg so hard. Wow.
Yeah.
See, is that fair? Greg's like, I mean, if there's something like this, and then put us on there. Like, you'll pick what yourself.
Sometimes, yeah.
We're gonna have one of you. I'm coming up with like a bamboo. This is exciting. That's so good. I have like so many things. About cardiology, electrophysiology, desktop. Okay, yeah, I was like, what am I doing? I don't think we're in yet. What is your thoughts? I was also here Yeah, I saw that. I consider. Actually, I like haven't watched that like I feel like one day maybe. I don't know. Yeah, but I feel like it's not working on I just leave the apartment. I walk out and maybe 7 people are like, they're slacking. No pharmacy. Yeah. And that's the thing, it's like, do that. People like their reception. They don't know you're there for 7. No, it's the images. It's like everyone who's done work left in. Yeah.
Hi everyone. I think we're going to get started for the evening now that everyone has their food organized. So I wanted to say thanks so much for coming out tonight and welcome to the CSHP Fall Update. We have had a record turnout tonight from my 2 years that I've been running this, so you know. And I think it's because we have such strong presenters, and tonight is obviously no exception. So I'm just going to introduce you guys first to Dr. Ksenia Chernushkin. Ksenia hails from her undergrad at the UBC Faculty of Pharmaceutical Sciences. She graduated in 2010, and after that she did her residency in 2011. She worked in VGH after that in a variety of practice areas that have made her a very well-rounded pharmacist. She's done work through the CSHP Council, so she's very familiar with these sorts of events, and she did her PharmD at U of T in 2018. In February of 2018, Ksenia took on quite a novel position through the Royal Columbian Hospital in opioid stewardship, and that's what she's going to be presenting on tonight. And then on top of that, she has a newfound interest in drawing, so she's artistic in addition to being scientific, which is amazing. And she loves reading to her son, who is 15 months old. So if everyone can give a round of applause for Ksenia.
Hello, everyone. It's really a thrill to be here, and I found out that I have all these connections from my previous experiences with pharmacy, and a lot of people moved up here. Apparently, I know, so it's really great to see some familiar faces. And I'm really excited to be here and share a little bit of expertise that I've gained and knowledge on this really novel idea of opioid stewardship, and talk a little bit about the opioid crisis. So I have no current or past relationship with commercial entities. I have received a speaker's fee for this learning activity, and this program has received no financial or in-kind support from any commercial or other organization. So I hope by the end of this presentation that you're able to explain how opioid prescribing practices have contributed to opioid misuse and the opioid epidemic, and describe the objectives and principles of opioid stewardship, and maybe list the 7 potential opioid stewardship interventions that pharmacists can incorporate in their daily practice to support safe and effective opioid prescribing. So 2016 was a big year. It was the year that the Brits decided to get out of the European Union. We all watched in awe Donald Trump being elected as a president of the United States. And it was also the year that the opioid epidemic was put on the historical map. In April of 2016, BC declared provincial public health emergency due to the opioid crisis. And actually the statistics that came after that were quite astounding. Canada is still the second largest user of prescription opioids in worldwide. And we actually know that for every 100 Canadians, there are 53 opioid prescriptions being filled. In fact, current statistics show that opioids are one of the top 5 causes of death, topped only by cardiac death, respiratory diseases, suicide. So it's still very much an issue, and it's been on the news a lot, and there's been a lot of initiatives within healthcare, but we're still struggling to control the issue. And you can see it from this infographic. This is a rate per 100,000 population of opioid-related deaths. And you can see this is really well color-coded, so you can see that BC is definitely the province that suffers from this affliction the most, followed very closely by Ontario. And the statistics are still very shocking. Over 12,000 Canadian lives were still lost between January 2016 and March 2019 due to opioids. And just between the January and March of 2019, opioid-related deaths rate in BC was 23.8 per 100,000 population, which is a bit of a hard number to wrap your mind around. But what you could think about is from January to March 2019, the number of apparent opioid-related deaths in BC was 299. So how did we get here? And the history goes quite deep because opioids have been around for a really long time. So in the early mid-1800s, morphine was a widely used drug on the battlefield, and a lot of the soldiers became addicted to opioids. Later, diacetyl morphine was produced and introduced as a safer opioid. And this sounds very familiar, right? We've been told, when the OxyContin was introduced to the market that it was a safer opioid to use. So history repeats itself, and it wasn't until the 1914 Harrison Narcotics Act that required written prescription for opioids that opioids were widely used for all kinds of afflictions: stomach pain, toothache, sleep deprivation. And the Harrison Narcotics Act actually produced a very wide effect where opioids were not as widely prescribed, and actually we swung the other way. What had started happening is what was termed later as an opiophobia, where patients who truly had the need for opioids as pain management were unable to get access to the drug. And these patients included, back then, terminally ill HIV patients, as well as patients with cancer pain. They were essentially told to wean off the opioids as quickly as possible and only use it when their days were counted in weeks. So this certainly triggered a public outcry, and the American or North American organizations reacted to it and created a lot of policies around allowing opioid use or even promoting opioid use. At the same time, oxycodone sustained release was approved and introduced to the American market. And the American Pain Society essentially said, you know what, pain is the 5th vital sign. We need to control it really well, and we don't have a lot of tools, so please do use opioids. So then we started swinging the other way. The Joint Commission, which is an accrediting body in the United States, which accredits hospitals and healthcare programs, came out with a statement saying that every hospital should create new standards for better pain control, and opioids were widely popularized as an effective tool in doing so. And it wasn't until 2007 that the message clicked in that we were maybe going overboard. Purdue was found guilty of criminal charges for misleading on addictive properties of oxycodone sustained release, and we arrived at where we are today with the opioid epidemic. So there was a very interesting survey study that I ran across that basically surveyed patients with opioid use disorder and asked them, how do you think you got here? And the patients identified, there were around 300 patients, they identified 5 main pathways. Pathway number 1, in patients who had chronic pain and were prescribed opioids and repeatedly told by their physician that, no, this is the best drug to use and it's safe and effective, please continue, even though they themselves could tell that the use was becoming problematic. Brief episodes of opioid use for acute pain management, so post-surgical pain, tooth extractions, that later led to problematic use. And use of opioids in patients with substance use. And these patients were quite incredulous. There are statements in the survey stating that they are really not sure why their physicians thought it was appropriate to prescribe opioids, knowing the history of substance use.
but it was because we thought it was safe. We thought it was the most safe and effective option out there. So these all describe prescribing practices that could be modified and technically should be an easy solution to reverting these issues. Pathway number 4 was prescribing opioids for pain initially. That became problematic because people often find that opioids treat the emotional distress, not necessarily the pain itself. And again, this is another problem with the type of prescribing that was being done. And pathway number 5 were recreational use, and this is still very much an issue, recreation initiation or non-medically supervised use of opioids. It's no wonder that the prescribing practices have affected the opioid crisis so much, because almost 30% of Canadians suffer from chronic pain. And an excellent summary from the Health Quality Ontario actually states that 1 in 7 people in Ontario filled an opioid prescription in 2015-2016, and it's very likely that a large proportion of these patients are chronic pain sufferers. The total number of opioids, as per report, opioid prescriptions remained steady in the 3 years that they surveyed. So this was from 2014 to 2017. So just in summary, the factors in the emergence of prescription opioid epidemic were propagation of misconception of opioid safety, so low risk of dependence and low risk of addiction in patients who truly have pain. Risk of overuse was promoted as being minimal, especially with controlled release drugs. The declaration of safety and the effectiveness for more widely accepted indications that we had evidence for, so things like chronic pain, and reservation about long-term use, safety, and use of alternative medicines like NSAIDs. This letter from 1980s made quite the ripple effect. Essentially, the author stated that they surveyed about 11,000 patients in hospital who received opioids at any time during hospitalization, and they found that only 4 of these patients developed opioid use disorder. They concluded that despite widespread use of narcotic drugs in hospitals, the development of addiction is rare in medical patients with no history of addiction. And guess what? We believe them, because about 600 citations exist that use this index publication to support opioid use and chronic pain management as a safe option. Other factors were pain should be treated to the fullest. This was the message that everybody heard, and physicians had a lot of pressure, and there's a lot of articles out there floating from physicians practicing in the 80s and early 90s that there was a lot of pressure to control pain, that the nurses were after them, the patients were after them, and the only tools that they had were, NSAIDs and some non-opioid therapies, but opioids were a key tool that they used. And of course, the opioid endorsement by the national organizations like American Academy of Pain Medicine and American Pain Society, they essentially are the bodies that publish guidelines that said opioids should and could be used as a safe option. So just to give you an example, this is a consensus statement from some of these bodies that keyed a new term called pseudo-addiction. I'm not sure how many of you have heard of this. Essentially saying that individuals whose behavior that may suggest addiction sometimes reflects unrelieved pain rather than addiction itself. Or this publication that pain is the 5th vital sign, essentially that the pain needs to be controlled just as much as blood pressure and fever, that it is essential to basically control it to the maximum. We've generally been able to come back a little bit from this. There's been new publications out there, the CDC guideline in 2016 and the 2017 Canadian guideline, which revert back to suggesting use other therapies before trying opioids, use minimum amounts of opioids for short amount of time, and really judiciously use opioids long-term as well as long-acting opioids. I'm not sure what's happening. Sorry about that. Thank you. The American guidelines are actually used as part of lawmaking in some of the U.S. states. They are criticized a little bit for being stringent, and the Canadian and seem to have quite the strong wording, considering the evidence is still largely lacking for all of these recommendations. where the Canadian guidelines seem to have a more reasonable approach and a more reasonable wording, but both could be used for practice. And of course, the College of Physicians and Surgeons of BC came out with standards for practice, which addressed primary prevention of overdose addiction and other harms. And they specifically stipulate that these standards do not apply to patients suffering from cancer pain, palliative patients, and management of substance use disorder. The standards also, aside from opioids, address the use of benzodiazepines, sedatives and hypnotics, and barbiturates. The Opioid Wisely campaign, which was put together by Choosing Wisely Canada, is also a great resource. And they also promote use of opioids as non-first-line therapy, as well as an interesting approach of compassionate prescribing. They basically helping us to be aware that there are still patients who require opioids or patients who have been on opioids as chronic therapy. They still need prescribers. They still need someone to reassess their use, and some of them will continue using opioids. This is basically just cautioning us that we can't just stop opioids on everybody because they're the big bad wolf, that some patients still have a true need for them. The systematic review like this one are also helping us make more judicious decisions. This was a study that basically looked at opioid therapy versus non-opioid therapy and evaluated whether there's any evidence for use of these drugs, for use of these therapies beyond 1 year. And guess what? There really isn't. We don't know how safe these medications are compared to not using these drugs past 1 year. There is, however, mounting evidence of lack of safety, an increase in overdose and opioid abuse, and side effects such as fractures and myocardial infections. So they've concluded that evidence is insufficient to determine effectiveness of long-term opioid therapy for improving chronic pain and function. Another systematic review looked at over 300,000 patients that received opioid analgesia for at least 7 days. And they found that 4.7% of patients prescribed opioids for pain developed iatrogenic opioid dependence or abuse with a number needed to harm of 21. This is more local data. This is Canadian data from Government of Canada report. And it shows that 1 in 8, or about 12% of Canadians, at least 15 years of age, reported use of opioids in the previous 12 months. And 3% among users of opioids, pain relievers, report problematic use. And there's no difference between males and females. We also now know, based on a cohort study like this one, that the longer you use opioids and the higher the doses you use, you're running a higher risk of developing opioid use disorder. So the risk increased from 0.12% in patients who receive chronic opioid therapy for up to 90 days to 1.3% with chronic therapy use past 90 days, as well as 0.7% patients develop opioid use disorder if they were on opioids up to 36 milligram day morphine equivalents, compared to 6.1% at higher doses of 120 milligrams. We've gained some ground, there's no question, and you can see on this infographic that prescribing rates of opioids have been declining, and BC has gained a lot of ground, followed very closely by Ontario and Nova Scotia, Alberta, of about 14% decrease in opioid prescribing. But what we should really be cautious about is, we know historically we've gone back and forth. We've gone through wide opioid use to opiophobia, where we're denying appropriate therapies to patients, and back and forth we go. So this is where opioid stewardship comes in, and it plays a role in finding a balance and finding judicious prescribing, appropriate monitoring, and screening patients for risk factors before we prescribe these drugs. So the ISMP Canada basically defines opioid stewardship as an approach to optimizing, monitoring, and evaluating opioids with the goal of supporting and protecting human health. And this is a program that's largely at this point modeled after antimicrobial stewardship, which has been part of accreditation standards now in Canada. And we're seeing that in the States, opioid stewardship is becoming part of accreditation as well. We like to say that opioid stewardship is not about less prescribing, but about better prescribing. And it definitely does not address prescribing in cancer patients, palliative patients, and patients with opioid use disorder. So we were urged by our CSHP president and internal liaison in 2018 to become, all of us, to become advocates for better opioid prescribing and to basically have a shift in the paradigm, shift in our practice. And I think as pharmacists, we're in the best position to do so. We have access, easy access to our patients. We have access to and ability to assess patients before we start these opioids, as well as assessing patients who are already on these treatments. And provide monitoring, provide education, identify patients with risk factors. I'm just going to flash this very quickly and not go through this, and I know the slides will be sent out to you, but there's a really wonderful article published by the Toronto group, and Dr. Laura Murphy is also a PharmD who is a leader in opioid stewardship out in Ontario, and she's published a really interesting article guiding pharmacists and in basically using the new guidelines, opioid guidelines, and implementing them in daily practice. So I strongly encourage you all to have a look at it. But I want to share a little bit of our experience as opioid stewards, and I want to do that by using a case. So this was a patient that I'd seen on as a result of our screening process. This was a 70-year-old female with no known allergies and acute and chronic back pain with decreased sensation and dorsiflexion in feet. Her MRI had shown severe vertebral canal stenosis in L4 and 5 region and lumbar spine spondylosis. She was admitted for L4-5 laminectomy, and I assessed her on post-op day 5. Her past medical history included hypertension, obstructive sleep apnea, degenerative disc disease, low back pain, obesity, and depression. So when I interviewed her and asked her about her pain using the PQRST approach, she told me that the pain was in the lumbar region. It was better with rest. It was intermittent, sharp, and stabbing. It radiated to her legs, but on the day of the assessment, she told me that it basically was between 0 and 3 out of 10 in the last 48 hours. So there's been some improvement. She has it at various times of the day. It's worse with activity. It definitely affects her mood and her ability to perform IADLs. She does have poor nighttime sleep and poor balance and due to numbness in her legs, and she has frequent falls. Her medications prior to admission were gabapentin 800 milligrams 3 times a day and Tylenol 3 2 tablets 4 times a day regularly. I have to mention, I didn't put this on the slide, this was not how the Tylenol 3 was prescribed. She essentially used the PRN prescription regularly. So as part of the screening process, this is what I see on my screen, aside from patient identifiers. I would have seen that, this lady's using multiple opioids. There's the sufentanil PRN, the hydromorphone long-acting, the Tylenol 3 is regular or scheduled, and the hydromorphone short-acting that's being used PRN. I don't know if you can see. Numbers here are really difficult to interpret as part of screening because they represent use throughout the entire hospital stay. So if it's a 0, it tells me some information, but if it's a number above 0, then I still don't know very little until I look at the profile. So then I generally look into the EMR at the patient's profile, and this is what I found, that she was using long-acting hydromorphone, which was initiated in hospital. She used the same dose of Tylenol 3 as at home. Her gabapentin was continued. In terms of PRNs, she was receiving short-acting hydromorphone, about 3 milligrams in the last 24 hours. Naproxen was prescribed PRN, and she'd used up 1 dose. Acetaminophen was prescribed PRN. She didn't use any of that. And sufentanil was prescribed PRN, which she also didn't use. Oh, and lorazepam. I noted through the nursing notes that the was being given to her for mobilization as well as sleep. Always an interesting finding. So we use several tools to help us in our practice, and the opioid screening tool, which is available freely on the internet, is advertised as a very simple way to assess whether patients are at high risk of opioid use disorder. And you have to score lower than 3 to be a low risk. If you're scoring higher than that, then you're at a moderate or a high risk if you're at 8 or above. But I find in practice this tool is not very easy because it asks really hard questions. Sure, there are not very many of them, but when you come into the patient's room and you want to quickly assess their pain and you have to ask them about the history of pre-adolescent sexual abuse, that's a long conversation potentially. So we do use it, and I do encourage you all to look at it and maybe think of ways that you could approach your patients. And I know we're all really strapped for time, and this is only one issue on the list. But there are ways to do it. There are ways to extract this information from previous charts and other healthcare professionals' notes. But I do want to say that despite advertising, it isn't a simple tool to use. So in our patients, she scored 1 for depression and being a female. My colleague, Dr. Karen Ling, who works as an opioid stewardship pharmacist at Surrey Memorial Hospital, and I have developed this tool for pharmacists, our colleagues, essentially to use. This is also another screening tool that we've encouraged pharmacists, and we've presented this to physicians, to use to identify patients who might be a good candidate for assessment by an opioid stewardship pharmacist or by a clinical pharmacist in general. And it's subdivided into patient factors and medication factors, and into yellow flags, which are basically warning signs, and red flags, where we strongly encourage referral to opioid stewardship. I'm not going to go through all of it and due to shortage of time, but I will just highlight that the patient that I'm discussing had a few yellow flags in patient factors for psychiatric diagnosis and obstructive sleep apnea, and a few medication factors, so milligram morphine equivalent use of about 15 milligrams per day, and suboptimal acetaminophen or NSAID use. And one of the red flags, use of opioids in combination with benzodiazepines or sedatives. We found that optimization of non-opioid medications is a very simple intervention that could be basically done by any clinical pharmacist, and it's done very rarely. This was a point prevalence survey out of Surrey Memorial that showed that only about 40% of patients were ordered acetaminophen PRN, and only 39% of patients had it optimized. With NSAIDs, as you would expect, the situation is even more dire. No NSAID orders were seen in 88% of patients, and 5% were ordered NSAIDs only PRN. So we do encourage to look at your patient if it is appropriate to basically, if anyone's on opioids and receiving, whether it's PRN or on a regular scheduled opioid, they should be on an acetaminophen unless they have contraindications. And NSAIDs can actually be used in a lot of our patients. For some reason, we internalized this fear of using NSAIDs, but really I encourage you to consider it as a viable option. And then, of course, considering other non-opioid options like gabapentinoids, SNRIs, TCAs, and topical analgesics. So just to highlight, for my patient, she was on quite a high dose of gabapentin, and some PRN and naproxen was prescribed, and some was used, and acetaminophen, even though it was prescribed, it was PRN, and as you can see, none was used. Another intervention that we strongly encourage is assessing opioid use on a daily basis. I know this sounds unreasonable, and there's so many patients who come in on opioids and get them prescribed PRN, but pick your targets. Pick patients who are using their PRNs, especially those who are using PRNs at high doses, or patients who come in on opioids and continue using them, or who get started on opioids in the hospital as a regular scheduled therapy. And it is important to limit the opioid use to preferably less than or equal to 5 days, or maybe 7 days. And the reason for that is we know that the risk for opioid addiction starts to develop at 3 days of opioid use, and it's significantly associated with risk of opioid addiction at 5 days. And majority of surgical patients receive opioids for weeks sometimes when they go home. So we're so good at pushing them out of the hospital now with prescriptions. This is an excellent infographic that basically shows that there's no safe opioid dose, but we know there's some evidence that between 50 and 100 milligram morphine equivalents, you have increased the risk of overdose by 5 times. And between doses exceeding 100 milligram morphine equivalents, now you've increased the risk of overdose by 9 times. So really looking at the numbers, oftentimes it isn't morphine that's being prescribed, so get to know your conversion tables or download the CDC app. It has a really easy conversion tool, and do the conversions, because even the benign Tylenol 3 sometimes can mount up to significant amounts. So for instance, this patient that I'm discussing was using 24 milligram morphine equivalents in sustained release hydromorphone, 36 milligram morphine equivalents in Tylenol 3s, and 12 milligram morphine equivalents in hydromorphone PRN. So 72 milligram morphine equivalents. So we are really getting up there with the dose. And of course, the other intervention is avoiding opioids and benzodiazepine use. And you know, when I screen, I see so many patients prescribed PRN, lorazepam, just in case. And it's really tough to approach physicians and constantly nag about discontinuing these drugs. But if somebody is actually using opioids and actually using their PRN benzodiazepine, I think that's your target audience. Co-prescribing of these drugs is associated with significantly increased risk of overdose, especially in the aging population now. Restricting the quantity of post-operative opioids is something that I've mentioned very briefly, but we now know there's a lot of data showing that up to 92% of patients who are prescribed opioids don't use them up after surgery. And that's why are we worried about that, is because of data like this that shows us that a lot of the patients get their opioids from friends, friends and family being very helpful. Oh, you know, I had a tooth extraction last year. I think I have some Tylenol 3s kicking around, so here you go. And for some people, that's all you need. That's the trigger they need, is to try it once or twice. I've had patients come up to me and say, you know, I had a knee surgery and I was given oxycodone and I started to like it a little too much, and I had to stop myself. And these are people who are able to recognize that issue and able to stop it in time, but not everyone can. And of course, considering risk mitigation strategies such as naloxone take-home kits. I usually approach every patient who's used at least 50 milligram morphine equivalents per day, but really consider it in elderly who are on opioids, patients with other risk factors. If you look at the yellow and red flags, other risk factors, who are using opioids and who have not had a naloxone kit given to them, do the education and give it to them. And then, of course, establishing appropriate use and safe practices, so universal precautions. Some of them don't apply in hospital, but this is something you can recommend to your family physicians that work in the hospital, your hospitalists, that needs to be put on the discharge summaries, things like urine drug tests, which we think are so invasive and no one wants to do them, but really they're the only tool we have to help these patients. Think of them as not berating strategies, but things to help the patient to stay on track. And lastly, a lot of education and empowering patients with information about what chronic pain is and what the expectations should be. Empowering them with the mechanism of how the drugs work, what the safety and efficacy of these medications are, and setting expectations. A lot of chronic pain patients will continue to experience some degree of pain on chronic basis. It's just that never had sent that message to them. No one has ever said that out loud. You know, we're just trying to control the pain. Discussing adverse effects and planning for safe storage and disposal. I find that we as pharmacists are pretty good at safe storage, but I don't know that we all address disposal. So if you had not used your supply of Tylenol 3s or Tramosets or whatever we gave you, please take it down to the pharmacy. Don't keep it at home for use at a later date. So this is a very long list of recommendations, but essentially we've started on the track for deprescribing gabapentin, and the dose is really high, as I'm sure you all know. It exceeds what's the evidence-based maximum dose for efficacy, and there isn't really a huge role for gabapentin use in radiculopathies, so there's definitely room for trying tapering it down and see if there is if the patient has increase in pain. Changing naproxen to regularly scheduled for a short period of time just to manage post-operative pain. changing acetaminophen to regularly scheduled, discontinuing the Tylenol 3s. She did complain of insomnia, and I find there's kind of controversy and difference in opinion whether the caffeine in Tylenol 3 is enough to actually affect somebody's sleep. But I think in somebody who's elderly, who has poor sleep structure already, I think it is one factor that could be eliminated, and we don't need to use this drug in particular. Discontinuing long-acting hydromorphone, which is really an inappropriate use, using the long-acting opioids for acute pain management. And then coming up with a taper. And I've included the dosing calculation, you can go through it, but essentially calculating what the current usage is and decreasing. I find that the rapid tapers are very effective in the short period of time after surgeries, especially if they're supposed to be quote-unquote curative. So you can go a little bit more rapidly, maybe every 3 days, slowing down if necessary. And by necessary, I mean the patient's experiencing really an increased amount of pain, significant increase in amount of pain and withdrawal effects. And then slowing down. And the range is really big for opioid tapers is 7 to 14 days. You can kind of see how your patient is doing if they're still in hospital, or you can advise the family physician to see how the patient is doing and what their motivation is. And you can decide between the range of 7 to 14 days what's more appropriate for them. I would have changed the PRN hydromorphone to match what my new recommended regular scheduled dose is, and really encouraging sufentanil use for mobilization as opposed to a more long-acting oral drug. Use trazodone PRN for sleep and discontinue the lorazepam. So just in summary, prescription opioids, as we all know, are associated with risk for dependence, addiction, overdose, and death, and have contributed largely to the development of the opioid epidemic. And the opioid stewardship aims to improve, monitor, and evaluate the use of opioids to support and promote efficacy and safety. As pharmacists, we're all opioid stewards, and we can all incorporate opioid stewardship interventions into our daily practice. Thank you very much, and I will take questions. Yes, please. So the question was whether whether there's any evidence that one opioid is more addictive than another, and whether we can. We think that a lot of this information is coming from the false advertising. So OxyContin played a huge role in this sort of myth that, long-acting opioids are less addictive. And then we swung the other way and we started really blaming the OxyContin for everything. But it was because it was a more used drug. There is currently no evidence that certain opioids are more or less addictive. We do, however, know that a specific opioid, buprenorphine, which is used as part of opioid use disorder therapy, and Suboxone, but there's also buprenorphine patches. It's a partial mu opioid agonist, and it just doesn't have the same CNS effects, and it doesn't have the same effects on the respiratory function. So we use it as a quote-unquote safer opioid, but it is still an opioid. It just has a lower risk of adverse effects. But other than that, I hear, Tramadol is less addictive. It is just as addictive as every other opioid. Some are more potent, so they may create more, for instance, especially with parenteral use, when we use parenteral hydromorphone and parenteral morphine, you may experience more side effects, CNS side effects with hydromorphone compared to morphine. But it's really a matter of potency and using equivalent doses. Yes?
Thanks for the presentation, Sonia. I have a question about the maximum safe dose of acetaminophen, especially in elderly patients.
Mm-hmm.
I see. So when I went to school, it's still a gram QID, and I've been hearing a lot more we should be cutting that down to 650 QID, but I haven't had a chance to look into the data. And I noticed in your case, you just put her at 650 QID, the 70-year-old. Can you go into that a little bit about what the data is around safe dosing?
So the question is about the maximum safe dose of acetaminophen, whether there's any specific data on anything less than 4 grams in particular populations. There isn't specific data. I do find that there is generally now a culture around using 3 grams as a maximum in elderly patients. And frankly, I do it because I know that if I go 1 gram QID, then the physicians will come around and change it to 650 QID. And I'm not sure where this is coming from. I mean, I still think that you will get quite a bit of majority of benefit from 3 grams in an elderly patient. But I'm not aware of any specific data that 3 grams is safer than 4 grams.
Thank you so much. That was very great talking to you. I just wondered if you can comment on the opioid stewardship program in general. Like I know with antimicrobial stewardship, like we have these checks and balances, audit feedbacks. Do you foresee a time in the future where as opioid stewardship grows, we will have those same checks and balances? Like we will target this duration for this type of surgery, or target this MMAE for this type of patient population, and have those same data to help support and guide clinicians when they identify opioids?
Mm-hmm. So the question is about, to comment a little bit more about the opioid stewardship and whether there's potentially in the future going to be sort of standard principles and standard approaches. We hope there will be. So currently opioid stewardship in Canada, in hospital, is basically myself and my colleague, my partner in crime, Dr. Karen Ng at Surrey Memorial, and we are led by Dr. Mike Legal, who is our supervisor. So the 3 of us are putting our heads together and trying to figure out methods. We are largely modeling the program at this point after antimicrobial stewardship and trying to do the same process of screening, which we're now running into some issues with this process. It is definitely a lot more difficult to achieve with opioids. As you can imagine, so basically I take the entire hospital population and I screen for all patients that receive any opioids. You can imagine I have 700 lines in my report. So then I limit it by ward, and then I'm still stuck for an hour and a half just screening to even find the appropriate patients. So we're trying kind of multi-pronged approaches. The recommendations are based on the guideline, MMEs and the types of risk factors. So the yellow and red flags, that's based on literature. There's nothing new out there. We're just collecting information that's already existing and putting it together and trying what we call the multi-pronged approach. So aside from screening, we also take individual consults. We encourage pharmacists, physicians, nursing care leaders to contact us if they're whatever they think is a patient with problematic opioid use. And we find that the rate of consultation is very variable. Some days are really busy and others are not. And we still are finding that through screening, a lot of patients get missed. A lot of patients that really should have been put on our radar, but they weren't. So we feel like we kind of have to go both ways a little bit. But does that answer your question? And I saw another question.
Yeah, just a follow-up to Will's along the same lines. I'm really curious of the model that you guys are pulling.
Mm-hmm.
Specifically, do you have a physician or a prescriber associated with your program?
Mm-hmm.
And how do you get most of your interventions resolved? Do you work through the ward-based clinical pharmacist? Do you work through the MRP? Is it a combination? And what are some of the big challenges that you and Karen might face since starting?
That's a great question. So it's just a follow-up to ask a little bit more about the program and the model and how the interventions are made and whether there's a physician involved. We currently operate on our own. We do not have a physician attached, and there are no plans to apply for funding for a physician at this point. We work by multiple ways, and as clinical pharmacists, you know that every unit is a little bit different. Every physician is a little bit different. So as we're circulating through the hospital, we're learning a little bit about the practices on the units. Surgeons will be very different in approaching to resolve an issue compared to a hospitalist, right? They're just physically not there all the time. So we work a little bit through clinical pharmacists, but we do a lot of interventions on our own. We leave notes. We try to get a hold of the physicians. There's a little bit of leeway. We do have some limited prescribing authority in hospital as clinical pharmacists. For instance, acetaminophen prescribing is something that's available to us. But I think we're still in the process of discovering what works best. We are conducting an interrupted time series, which will hopefully show us whether our current approach is producing any results of significance. So we're doing it at the 2 sites that opioid stewardship is implemented, and we're hoping that next year we'll have the results. Yes.
Sorry, just to follow up to that. Can you comment on the metrics that you're looking at to measure success of the program?
So the question is about the metrics to measure the success of the program. You know, we're collecting every stat we can. We are collecting the stats on who we're seeing, the kinds of patients, and the kinds of interventions we're doing. So have we optimized non-opioid therapy? Have we discontinued opioids? Have we de-escalated, provided tapering regimen, etc.? Everything we can gather at this point we do. We basically have a running spreadsheet of this information that we, as I'm screening and seeing patients, I'm collecting. And of course, the Interrupted Time series is another resource that we hope will give us a little bit of information. But there's actually, there's some guidance from the states because they do have opioid stewardship programs in various settings. So there are some guidelines from the states showing what has worked in the past or what have been appropriate interventions that have been most effective in this role. So we're following a little bit their guidelines.
And is patient satisfaction part of that evaluation?
Not at the moment. Not at the moment.
That might be something to look at in the future in terms of their experience with respect to your service.
Mm-hmm.
Because even though you might not be resolving 100% of the drug therapy problem is related to opioids, they may still appreciate that, that discussion and education.
Mm-hmm. So for people tuning in, this is the comment is basically to look at patient satisfaction as a potential other factor of information together, that maybe the interventions, and you're right, we find that we're not only trying to get the patients on board, we're trying to get the prescribers on board, and often it's really out of our hands because these are prescribers in primary care, that all we can do is send our note or make a phone call, but we don't know whether this is actually our recommendations are being implemented. We do follow up, we do offer a phone call to the patients to follow up. Thank you. I think this is it. Thank you very much.
Thanks so much, Ksenia, for sharing all the work you do. If everyone has a few minutes, we can take a bathroom break and help yourself to some dessert, and coffees are on the table, and then after that we'll get started with Shaylee's presentation.
You should go this way. And if I have anyone else questions, I can so your taxi's coming downstairs, and we're running graduates. It's like checkmate taxi, and they You're welcome. Please take.
Questions on the big board there.
What other sites?
I know, yeah. Who's better off?
Do they like normally wasn't it someone's house? Oh really? That is now free. Passion is for you.
No one wants to.
You look so relaxed.
How are you?
I think I only opened it for lunch and then you Yours is the best.
You got it from you like Googled me? That's how you got this? I know. Understanding how that one. So it's like weird. Sound like that. Yeah. I did not know that until like 2 days ago. Oh yeah.
So they're like,
I went to a high school event. I feel like that's like what makes me do. Yeah, I learned a lot. My next one is so hard. You also become like 16. She was in and they were like Just do a presentation about early morning. Just like managing unstable years old. Okay. You gonna do that one? Yeah. Oh yeah. I really am.
And then like present kind of has on Wednesday.
45 minutes. No, I can't do that.
Like,
No, I can't do that.
exactly. Right? Pretty much, right? Full-time job? Oh, good.
You don't want to be blindsided like that.
Been here like 50 days. You won't.
I wanted to.
I did not graduate in do you think I did for 5 years? I must have been started. Yeah, I did start.
How did everything go? Like for dinner one? Awesome.
It won't let me change it.
I think I turned off edit mode.
The dessert's done till the end, so and then again, if you do have any other my staff is either in that kitchen or in the other room, so and then you're very welcome.
I think I turned off editing.
Okay, that's alright.
And I'll just show you now. You can see it hits Alt and tab here. You can just switch between whatever this thing. Like poll. You just need to Alt tab.
How will she know which is her right alt tab? The correct alt tab for her. Oh, it's just alt tab here.
Always Alt tab. I set it up so it'll go between the two. The Alt tab.
Otherwise, it's like we're gonna I'm so grateful for like my group of guys who we know how to like incentives and everything. Yeah, that Well, it's probably not kind of balance, but we have to get a price and what should you say I did for me?
They don't want any of it.
Yeah, we be the perfect.
Okay, everyone, I think we're going to get started with our second presentation for the evening. Running a little ahead of schedule, but I think that's okay. So next I'm going to introduce you guys, I'm sure almost everyone here knows her, but to Dr. Shaylee Peterson. I really Googled most of these facts about her, so they could be a little off here. So she didn't actually go to the UBC Faculty of Pharmaceutical Science as a graduate in 2010. She mostly started in 2010, so I apologize. She did her residency at KGH in 2015 and then completed her PharmD at UBC in 2017. And since then, she's been a clinical pharmacy specialist at Royal Inland Hospital in cardiology. And Shaylee has tons of other interests outside of pharmacy, most of them outdoors. So they include things like skiing, mountain biking, yoga, camping, hiking, all the good things the interior has to offer. So without further ado, if you guys could give Shaylee a hand, she'll be presenting.
All right, thanks so much, Claire, for the introduction. And thanks very much for inviting me to come speak here today. So we'll dive right in. There's going to be a little bit more evidence in this presentation, so get ready for going on an evidence-based medicine ride, as it always is whenever I talk about anything related to cardiology. I don't have any disclosures to disclose, and this program has not received any kind of support. So I'm hoping that by the end of this presentation, you will be able to make me a list of all of the options we can treat a diabetic with that would have some benefit on survival or reducing cardiovascular events. I also hope that you'll be able to kind of compare and contrast some of these therapeutic alternatives that you have with respects to cost and safety, efficacy, and the different routes of administration available. Also, by the end of the presentation, hopefully you'll be able to pick which of your patients are going to be most likely to benefit from some of these therapies, and then apply that all, of course, into an individualized pharmacotherapy plan for one of your diabetic patients. So we'll open it up with a case, and we'll just get our brains thinking about this guy, and then we'll come back to him towards the end. So this is like every other patient I see on my cardiology service in Kamloops, a 63-year-old, 75-kilogram man admitted to my cardiology service with an NSTEMI. Past medical history is he's a type 2 diabetic for the last 7 years, for which he's taking metformin, and he's got hypothyroidism, he's on some levothyroxine. The labs that I'm going to present to you is that he's got an A1C, that's 8.2%, and a creatinine clearance of 60 milliliters per minute. And I don't want to dig into all the cardiology stuff, so we'll just suffice to say he's on optimal cardiac medications. But the cardiologist turns to you and asks, is there any other drugs that we can use for this man to reduce his cardiovascular risk? So why do we care about diabetes and cardiovascular disease? Well, as you probably all know, diabetes is very bad for your heart. And there's some statistics saying that patients who have diabetes have a cardiovascular disease risk that's that of a patient that's 15 years older than them. So, and I don't think I need to convince anyone about this. We've all seen lots of diabetics with cardiovascular complications. So treating these patients and trying to prevent cardiovascular disease seems like a good target. Probably everyone has seen the Canadian guidelines. These were published in 2018, and I think we all know metformin is our gold standard first line for a diabetic, type 2 diabetic at basically any stage in therapy, whether they're just diagnosed, just on the cusp of having diabetes, or whether they have a very high A1C. And once we start seeing patients presenting with metabolic derangements, we might be looking at adding insulin. And you'll see that the 2018 diabetes guidelines basically state, does this patient have cardiovascular disease? And if they do, it gives us some therapeutic alternatives in empagliflozin, liraglutide, and canagliflozin. And then if those fail to reach their target, then moving on to some other agents. And basically, since you have probably all noticed, a lot has changed and a lot more evidence has come out since these guidelines were published. So I just want to make sure we're all up to speed on what the latest is. So I actually spent an embarrassingly large amount of time on this slide, even though this is just like the background slide. But it's like, how many agents do we actually have for diabetes available in Canada? And there's actually a lot. Like, I was on that, like, you know, Health Canada drug product database. Like, is this one in Canada? Is this one in Canada? Because these are always changing, and there's so many different agents. So we won't, unfortunately, have the opportunity to go through all of these classes of agents, but we will hit on most of them. So I figure, you know, most of us are probably all pretty comfortable with metformin and probably have all heard about the data for metformin, but no presentation is complete without, you know, doing our justice of thinking back about what's actually been studied. So we've all probably heard of the UK PDS trials, but probably most of us forget what they actually looked at and how they were actually conducted. So we'll just do a really quick review. So the UK PDS 34 was a fairly small open label RCT, but it was randomized and the patients were followed for 10 years, or just over 10 years. The patients that were specifically compared with metformin and their placebo or diet were specifically overweight type 2 diabetics that were recently diagnosed. And again, metformin was actually titrated to a glucose level, mean dose of about 2.5 grams a day, and then it was compared to just like a diet plan. That was their placebo. So again, open label, this wasn't a placebo-controlled trial. And they did find fairly dramatic results. They found a reduction in all-cause mortality, macrovascular disease, as well as diabetes-related endpoints, which is the composite of macrovascular and microvascular complications. In terms of adverse events, there was almost no adverse events documented at all from this trial, but they did say there was some minor hypoglycemia, but nothing major, and that's all they commented on adverse events. But I think we all know the common adverse events from metformin, mostly just the GI side effects. So I wanted to make this presentation interactive, and I also would like people off-site to also please participate. So those of you who have Survivor on in the background in Kamloops, please turn that off and focus on my presentation, and you can answer this question. So if everyone can pull out their phones, you're allowed to pull out your phones for this. I encourage you to, because it's fun. Search www.menti.com and then enter in that code, and then you can answer this question. And then we will see what everyone says. I'll open it in a second.
There's like a 30-second delay online,
so. Okay, so we'll wait. So they're just laughing at my joke now, is what you're saying. All right, everyone had a chance to, anyone having technical difficulties, that's working for everyone? Oh, look at that. Can everyone see that? Perfect. All right, so let's see. So I think everyone should be able to see that, but we're seeing that everyone in the room basically is saying this is false, that sulfonylureas have not demonstrated a reduction in cardiovascular events in patients with type 2 diabetes in a randomized controlled trial. So I'll give you the answer to that in just a moment. And what I will give you is basically the only randomized control trial that actually compares sulfonylurea to a placebo arm. And this is also a part of the UK PDS study umbrella. And it was the UK PDS 33. And again, like the metformin trial, this was an open label randomized control trial. This one was a lot larger. It had almost 4,000 patients. And again, it followed patients for about 10 years. Also looking at newly diagnosed type 2 diabetes or diabetics. And the intervention that they looked at was a little bit heterogeneous, a bunch of different sulfonylureas, some of which we don't use anymore, but that are similar to the sulfonylureas that we have available today. Or they could have been on insulin. And they also targeted a blood glucose number of less than 6 millimoles per liter. And their control was the same as in the metformin arm that we looked at. And these studies were actually all kind of done at the same time, so they were kind of being done in conjunction. And the control was also just diet. And they looked at the same kind of endpoints that we looked at in the metformin trial, but we didn't see the same results here. So there was no statistically significant difference in all-cause mortality, death, or any of the macrovascular endpoints, and we looked at those individually. What they did show a reduction was diabetes-related endpoints, so they saw a small reduction in this, but this was mostly driven by retinal photocoagulopathy, so that's like a surrogate marker of retinopathy, and that's what drove most of the results of this trial. So this trial didn't really give us a ton of convincing evidence for using these agents. However, some of you have probably heard, but I thought there was some data of benefit in for cardiovascular risk reduction. And where some of that comes from is they did do an extension of this trial. So at the end of this trial, patients were no longer assigned into their treatment arms, but they did do a follow-up 10 years later of these patients. So at this point, this was like 20 years after the start of this trial, and 10 years since they'd actually been on treatment, or at least randomized to a certain treatment. And they did see in 20 years there was a reduction in cardiovascular events and mortality in the patients who had originally been randomized to this sulfonylurea insulin group. So that is where some of, I think, what we hear about in that, maybe there is, because there's a little bit of controversy about, do these reduce cardiovascular events, do they not? So again, that's interesting hypothesis generating stuff. It was open label at that point, and patients could have been on any treatment. So it's hard for us to draw really firm conclusions from that. But I can say we certainly don't have a randomized control trial that has shown us benefit in terms of cardiovascular outcomes or mortality with these agents. All right, so you guys all got it right. That was false. So next, before I dive right into this, I want to give a little bit of the history about why I'm going to bombard you with non-inferiority trials at this point. So who remembers the drug rosiglitazone? I'm looking at the pharmacist who didn't just graduate 2 years ago. So actually, this because I corrected Claire in my bio, I will admit this actually happened before I was even in pharmacy school, but I'll fill you all in case you didn't get the memo. But basically, way back in 2008, we were seeing all of there was reports of increased cardiovascular events with patients taking rosiglitazone and heart failure and some of these negative things. So then the FDA basically mandated that from now on, all diabetes drugs the manufacturer, before they bring it to market, has to prove that they do not increase cardiovascular events. So prior to this, all that it took to have a diabetes drug come to market was they had to lower A1C. They had to lower blood sugars. They did that, you could bring your drug to market. But in 2008, they were like, okay, you have to lower A1Cs, and you also can't give people heart attacks. So this is a kind of a weird thing to get your head wrapped around. So then they mandated everyone had to do these big non-inferiority trials to prove that compared to a placebo, their drug did not make the patient do worse than the placebo. So it's a little bit of an interesting concept, but this is where all of our data kind of started coming out about the effect on cardiovascular events of these medications. So almost all these trials, they did non-inferiority trials, and then they also looked to see, was there any superiority? So we'll be diving into a lot of that evidence as we go forward. But some of the first kind of class of medications that came out since all of this stuff happened was the DPP-4 inhibitors. So I'll go through them first. So all of the DPP-4 inhibitors on the Canadian market has had one of these big non-inferiority trials done on it. And as you can see, all of these drugs basically demonstrated that no, they were non-inferior to a placebo, so they did not increase cardiovascular risk, but also none of them showed any signal that they were reducing cardiovascular risk or preventing cardiovascular events or decreasing mortality. And in fact, the SAVOR-TIMI 53 with saxagliptin actually showed a statistically significant increase in hospitalizations for heart failure with that medication. So that kind of raised a few alarm bells there. And these trials were all designed basically the same way. And the population that they looked at was specifically patients who either had cardiovascular disease or were at a high risk of cardiovascular disease. And that's going to become a recurring theme with all of these trials. So basically my Cole's notes of DPP-4 inhibitors is that they don't increase or decrease cardiovascular events or mortality, but there is a potential signal that they could increase hospitalizations for heart failure. So next up is the slightly more sexy GLP-1 receptor agonist. So glucagon, like peptide-1, is basically a hormone that causes your body to release more insulin and also kind of affects like satiety and like your gastric emptying. So it was thought it would have all these beneficial effects on your glucose control and maybe weight and things like that when these were brought to market. So that's how they're believed to work for diabetes. And again, there's a lot of these drugs available on the Canadian market: exenatide, lixisenatide, liraglutide, semaglutide, and dulaglutide. Say that 10 times fast if you want a tongue twister. And all of these trials have had these landmark non-inferiority trials done as well. Again, these were all patients who, the patient populations varied a little bit in each of these trials, but in general, to summarize for everyone, to make it easier, they were either had cardiovascular disease or had a lot of risk factors for cardiovascular disease. So that's really the patient population we're looking at. And as you can see here, there's a little bit of heterogeneity in the results in what they found. So one of the first trials that came out was liraglutide in the LEADER trial that did show the reduction in cardiovascular events and mortality. But some of the following trials didn't show any difference, and some of them just showed a reduction in cardiovascular events. Most recently, which was published like a month ago, was the dulaglutide REWIND trial, looking at a weekly GLP-1 receptor agonist. As I think most of you are familiar with, these are all subcutaneous injections that are available in the Canadian market right now. There is an oral form of semaglutide that is just been studied and actually does have a trial the same as these. I haven't gone through it because it's not yet available in Canada, but it had similar positive results of reduction in cardiovascular events and mortality. So we're seeing that with the oral version as well, but stay tuned for that. Because in the interest of time, I'm obviously not going to be able to review all of these trials for you because we would be here all night and you might not enjoy that very much. But I picked kind of the landmark trial from each of these classes that we'll dig into with a little more meat. But all the references are here if you want to go in and look a little bit harder at all of the trials. And then we'll look at a meta-analysis to kind of bring it all together. So the landmark trial was a double-blind randomized controlled trial over 4 years. I'll give you the specific patient population included in this. So patients with type 2 diabetes with an A1C still over 7 after being on metformin if they could tolerate it. And then they had to be a specific age and then a certain number of cardiovascular risk factors depending on what their age was. The patients excluded from this trial were patients who were using mealtime insulins and patients who had known thyroid cancer because of some concerns about these agents and endocrine cancers. The intervention that they looked at was liraglutide, 1.8 milligrams sub-Q daily, and then their outcome was a composite of cardiovascular death, MI, or stroke. And this is the same composite that we'll see come up in all of these trials. And the results, as I'm sure probably most of you are familiar with, it did show a reduction in its composite endpoint. So almost a 2% absolute risk reduction, so a number needed to treat about 53 patients over the 4 years. And there was also a significant reduction in mortality. So this was like a 1.4% reduction absolute, and then that gives us a number needed to treat of about 72 patients over 4 years. The side effects seen in this trial are the kind of commonly known side effects with all the GLP-1 agonists, and those are the GI side effects, so like lots of nausea, vomiting, diarrhea, some injection site reactions. And then in this trial, they also did see a signal of more pancreatic cancers and kind of biliary issues in patients who were randomized to the liraglutide. I'll give you a kind of a quick appraisal of this trial. So overall, they did well describe their randomization and their blinding, and they did a good job of those. They reported all their endpoints, and they did all of the analyses that they said they were going to do, and they accounted for all their patients. In terms of limitations, they didn't fully describe allocation concealment. This was a study that was funded by the manufacturer, as all of these trials have been, so take that as for what you will. One of the common criticisms, or one of the criticisms I've heard of this trial, is that when you do look at the numbers of patients in terms of the other therapies they got, there was slightly more patients in the placebo arm who ended up getting sulfonylureas and insulin. So if you are of the belief that those could negatively affect your cardiovascular risk, then some people say that could have biased to showing benefit of liraglutide. But I'm not completely sure I buy into that based on the data that's out there. So kind of my summary of this trial is I do think it was overall a fairly well designed and well reported trial, and I do believe the results of it. I do think that liraglutide does reduce cardiovascular events and mortality likely in patients with type 2 diabetes and high cardiovascular risk. So again, instead of going through all of those other trials, I thought I would take you through a meta-analysis. So this is a meta-analysis that includes all of the trials that I listed before, so of all the drugs available in Canada, and then it also does include the Pioneer 6 trial, which is the oral semaglutide trial, so that's the only one in here that's not available in Canada, and then the Harmony is another type of GLP-1 agonist that's not available in Canada either. But this does include all of the other therapeutic alternatives. So I will orient you to this forest plot that we have here. And I apologize if people on the line or on the teleconference won't be able to see this, but hopefully I can explain it. So I think we're all used to looking at forest plots at this point. So we have over here is that we're seeing a favor of the GLP-1 agonist, and on this side we're seeing that we're seeing a favor of the placebo, and this is our line of no difference. So if our bars cross this line, then we are it's a negative trial, or it's not a positive outcome. And then we have all of our trials here. This top forest plot that we're looking at is the composite of major adverse cardiovascular events. So as we can see, the I-squared, so that's the statistical heterogeneity in these trials, is 40%, and we are seeing that. Not all of the confidence intervals quite include each other, but they're pretty close, and everything's generally in the same direction. So a little bit of heterogeneity there, but we do see at the bottom our open diamond is our point estimate, and that is clearly on the side of favoring the GLP-1 agonist for reducing MACE. And that's a statistically significant difference, or a statistically significant finding there. And we see similar results over on the bottom for all-cause mortality. You will see at the very bottom of this forest plot here in the Pioneer 6 trial, so that's the oral semaglutide trial, that's actually like a little bit of an outlier over there. And this has quite wide confidence intervals because it was actually the smallest trial done out of all of these. So it is, it could be moving our point estimate a little bit, but it will have the least amount of impact on our final point estimate compared to all of these trials. So basically, my summary of what we're seeing there is that In terms of benefit, we are seeing a relatively consistent benefit on all-cause mortality as well as reduction in cardiovascular events. In terms of adverse reactions that we're seeing, there is no difference in this meta-analysis. They didn't find any difference in pancreatitis, pancreatic cancer, or thyroid cancer, so that is reassuring. Individually, a lot of the other randomized controlled trials didn't show signals of these. It was mostly just the leader trial. And they did report that the gastrointestinal complaints were common. So, and I think we all have seen that in patients who are on these agents. So basically, my summary or my Coles notes of the GLP-1 receptor agonists is that they do likely reduce cardiovascular risk as well as all-cause mortality. Specifically, liraglutide, semaglutide, and dulaglutide are the specific agents who have had positive trials. We do see some heterogeneity and variation in the results of these trials, and I don't know whether or not this is a result of slightly different populations being studied in each of these trials. Some of these trials were in patients who had just had an acute coronary syndrome, and some of them were patients who had established coronary disease, and some of them were patients with just risk factors for coronary disease. So that could have affected why some of these trials were positive and why some of them were not. It's possible that it's not a class effect and that some of these agents do work a little bit differently than each other, or it could just be chance that some of the trials are negative and some of the trials were positive. So we don't really know, but overall it's looking sort of consistent. And again, the main side effect is those GI issues with no real other big red flags that I'm super concerned about with these agents. Any questions? Is that clear? Okay.
Shaylee, what proportion of patients in the GLP-1 studies continued on metformin? 100%?
All very high rates. Yeah, very high rates. So I think almost all of them were already on metformin coming into them. Some of them it was an inclusion criteria, or it's if they could tolerate it, but very high rates. All right, so now let's move on to the SGLT2 inhibitors, which you've all probably been hearing a lot about lately. And this is where we'll probably spend the majority of our time because they're kind of our newest, hottest topic out there right now. So all of you have probably heard about a lot of these trials because they all made quite a lot of noise when they first came out. So these are the 3 SGLT2 inhibitors that are currently available on the Canadian market, and there's more coming. But right now we have empagliflozin, canagliflozin, and dapagliflozin. And again, they all had their big non-inferiority trial and they included patients who either had cardiovascular disease or were at high risk of cardiovascular disease. And they all tested for non-inferiority and they all found that. And then they all went on to look at for superiority. And you've probably heard about the EMPA-REG outcome trial, which was kind of the landmark trial in this area. And they found that the empagliflozin did reduce cardiovascular events and mortality. And the canagliflozin, the CANVAS trial, which came out a couple years after that showed relatively consistent results, but not quite as big of a magnitude, and they didn't show the difference in mortality like the empagliflozin trial did. So for this class of drugs, the drug I'll really dig into is the empagliflozin trial, because that's probably what you're going to be seeing used the most and might be recommending the most because it's what we have available, and we'll go through this more carefully. So the EMPA-REG trial is probably not new to anyone, but I will just review some of the little bits and pieces of it. So again, it's a double-blind randomized controlled trial, very large trial, about 7,000 people, that was done over 3 years. The population that they looked at was very similar to all of these trials, so patients with type 2 diabetes and an A1C above target, so 7 to 10% depending on how long they'd been treated for their diabetes. These patients had established coronary artery disease or stroke or known vascular disease. And they did exclude patients with renal functions below 30, based on the mechanism of the drug. So I forgot to mention this. I think probably most people are familiar with it, but the way these drugs work is a novel mechanism of inhibiting glucose uptake in the urine. So it basically makes you pee out sugar. So that sounds like a great idea for diabetes. So that's why they studied it. The intervention that they looked at was 2 different doses of empagliflozin, so the 10 milligram once a day and 25 milligram once a day. And all of the outcomes that I'm reporting to you were a combined analysis. So they put like all the data from the 10 milligram and the 25 milligram together. It was placebo-controlled. Their composite was the exact same as what we saw in the leader trial, CV death, MI, or stroke. And what they found was also a positive effect. So obviously not inferior, but also superior. So 1.6% reduction in the composite, which was a number needed to treat of 62. And then an even bigger magnitude of benefit for all-cause mortality. So 5.7 versus 8.3%, which gives us a number needed to treat of 38 over 3.1 years. So that's a fairly robust reduction in mortality, and that's why we probably all heard a lot about this. One of the other surprising things that they also found was one of their unique endpoints was heart failure hospitalizations. So they also saw quite a reduction in heart failure hospitalization, and that has driven a lot of the future research in this, which you've probably been hearing about in the news lately that we will not dig into. I will tell you that the study was powered to detect these outcomes, again, with the 10 and 25 milligram groups put together. But they did do subgroup analysis and actually didn't really see any trend towards a dose-dependent effect. So that's something for you to think about when you're using this medication, that you'll probably get most of the bang for your buck from the 10 milligram dose in terms of the endpoints of death and cardiovascular outcomes. You probably will get maybe a little bit more A1C lowering with the higher dose, but for the cardiovascular events, the 10 milligram dose seems to do it. In terms of adverse reactions in this trial, they saw a very high rate of genital infections, and it was actually a fairly high rate in the placebo arm too, but in the intervention arm, it was up to 25% of patients did get a genital infection over the course of the trial. And there's a little bit of a misconception, I think, about the types of infections these are. So they weren't UTIs. These are fungal, yeast infections, and they were higher in I might mix this up. They're higher in men or women, and I actually can't remember which one it was, but they were higher in one group. But overall, it was high in both groups. So that is definitely a counseling point for your patients, and it's not UTIs. And that's the mechanism that makes sense in my head, but it's actually a genital infection. So that's just so everyone's aware of that. And then they also did see more cases of DKA in the empagliflozin group. But again, these numbers were super, super low, but there was a bit of a signal here coming out of this trial. Otherwise, they didn't see any increases in fracture or AKI or amputations. So my overall appraisal of this trial was, again, a fairly well-reported trial. They described their sequence generation, allocation, concealment, so it was well-blinded. They reported everything they were supposed to. They accounted for the patients, and the patients were well treated at baseline for cardiovascular disease. They were on statins, and they were on ACE inhibitors, and they were on the other drugs that they should be on with diabetes. In terms of the limitations, it did have a fairly long open label run-in period, so it did kind of select out for the patients that could tolerate and adhere to this medication. So those are the ones that made it into the trial. And they did have a high dropout rate, although it was actually higher in the placebo arm than in the intervention arm. Again, this was manufacturer funded. And again, we do see slightly more patients on all of the other blood sugar lowering medications that we have in the placebo arm. And that would make sense because the investigators were allowed to add on other medications to treat to target. And we do know these drugs do lower A1C, so if that's what you're using as your target, it makes sense more drugs got started in the placebo arm. But despite all these limitations, I do think it was a fairly well done trial, and I don't really think the limitations that I described would have really biased the trial in one way or another. So again, like the leader trial, I do believe the results of this trial. And I will now jump into a meta-analysis that was published 2 days ago by someone who trained me, Arden Berry, he works out of Abbotsford. And so we can tell our creditors why the slides were a little bit late, because I had to include the latest evidence, obviously. So this is a meta-analysis that includes all of the trials that have been published to date, and all of the drugs that are available in Canada. So, and one of these trials is very new, so this is a very up-to-date meta-analysis. And basically, this is a forest plot. It's set up the same way as the last forest plot. So on the left, showing a benefit of the SGLT2 inhibitors, on the right, showing the benefit of placebo. And the top graph, and this is our composite of all-cause, CV death, MI, stroke, or unstable angina. So again, we are seeing fairly homogeneous results. This actually has an I-squared of 0%. So all of these confidence intervals are including one another. So we're seeing quite consistent results from all of these trials. And again, our point estimate is a significantly finding of a reduction in the composite in the SGLT2 inhibitor group. And we see a very similar forest plot for all-cause mortality, again, with our point estimate being a significant finding with a risk ratio of 0.85 and relatively consistent results across all of these trials. So I liked this meta-analysis for just kind of summing up the overall totality of the evidence, but there was another interesting analysis done as well this year, a meta-analysis that was done a little bit earlier. So this one does not include the latest trial, but it does include everything else. And basically, this actually subdivided the trials out by whether or not the patient had established cardiovascular disease or whether they were at high risk of cardiovascular disease. So as we remember, that this was kind of like the patient population that they lumped together. And I thought the results of this meta-analysis were quite interesting and worth kind of something to think about, or hypothesis generating at least. But when they break it down and actually grab the data for the patients who had established cardiovascular disease, we're seeing that the benefit on our composite versus the patients who just had risk factors for cardiovascular disease, it looks like the benefit is potentially a little bit lost. So that could be an indicator of a subgroup that might have more benefit from these medications. So the patients who we actually know have cardiovascular disease are maybe the ones driving a lot of the benefit with these agents. The other finding from this meta-analysis that they looked at, which I'll present just because it's another cardiovascular outcome, was hospitalizations for heart failure in combination with cardiovascular death. And again, we're seeing a very consistent effect on reducing heart failure hospitalization, so more reason of why the studies are going the direction that they are in cardiology right now. So now let's do another question before everyone's eyes glaze over. So get on your phones and answer this question for me. The question is, SGLT2 inhibitors have been associated with which of the following side effects? DKA, fractures, amputations, or all of the above?
Shaylee, mine isn't working yet.
Oh.
It hasn't shown the next question.
Oh, I'm sorry, guys. Thank you for letting me know. Okay, I'm gonna hide it before you all answer. And I'll just give everyone a second on the line because apparently there's a delay there. So. All right, so let's see what everyone thinks. Ooh, I like this, a little bit of diversity. Yes. Okay, so we've got And this is good. I think there's more people answering here than there are in the room, so that means people are still like awake at the other sites, which is awesome. Thank you guys for coming. I appreciate you. So we're seeing most people are saying all of the above. We got some people saying amputations, some people saying fractures, some saying DKA. And the answer is you are all right. So let's go into that a little bit. So all of the things that I have listed have been fairly clearly and confidently associated with the SGLT2 inhibitors. So this is from that same meta-analysis that looked at all of the trials that have been published. So amputations have been increased, fractures have been increased. However, I will say that both the amputation and fractures were mostly just seen in the CANVAS trial with canagliflozin, and they actually didn't see them in the other trials. So I'm not really, I think it's something that needs to be on our radar, but I don't know if it's a drug-specific effect or if it's a class effect. I'm not really clear at this point, but definitely something we need to keep on our radar. The genital infections are seen across the board, so those are very high prevalence, whereas the other things are, more serious but very low prevalence. But the genital infections are definitely something you need to counsel your patients on. And then probably what is the most rare side effect of these medications, but also potentially one of the most scary, depending on how scary you think losing a toe is, but the DKA. So have people heard things about DKA? And I'm seeing nods across the room. So yeah, so this has been kind of off in the headlines, and we're seeing a dramatic hazard ratio of doubling your risk. But again, these numbers are still super, super, super low. But when it does happen, it can be, it's significant and can be dangerous. So I already gave away this, but yes. So you were all right. All of these things have been associated with SGLT2 inhibitors. So I want to talk a little bit more about the DKA. Has anyone else heard about this thing called euglycemic DKA now? Okay, so I'm seeing nods. So people have heard of it. So one thing I do want to point out too is that these agents aren't just causing the euglycemic DKA, they're also causing normal DKA too, but they are associated with this euglycemic DKA. So in case you're not familiar with what that is, a euglycemic DKA is the ketoacidosis, and your body's running on metabolizing, making ketones, but the blood glucose levels are normal. And the theoretical reason that this is possibly happening is because your body's still peeing out all the glucose, but you're not having enough insulin, you're not actually making use of that, so you're going into ketoacidosis. So this is a pretty scary thing because it's pretty hard to talk to patients about, and it's pretty hard to identify in patients because obviously a diabetic that checks their sugar and sees it's normal isn't necessarily going to think they're having a diabetes problem. So what I would advise is for all your patients that you do have on these agents is to provide them some counseling about things that they can look for that could be DKA, even if their sugars are normal. So the kind of things your patients can, DKA can present in a lot of ways, but patients can be super thirsty, they can have rapid breathing, they can be vomiting, they can be confused, loss of appetite, fatigue. So basically, it's hard to specifically describe this to your patient, but if they are feeling systemically unwell and they're a diabetic on one of these agents, they should be getting checked out because we would need to rule out the possibility that they're in DKA. The other things that we can do is educate ourselves, other healthcare providers, and the patients about what some of the common precipitants of DKA are, and then do some management in terms of holding these medications around these precipitants. So some of the precipitants of DKA are acute illness. So I think a strategy we could take, which is the same we use for other diabetes medications, is the sick day management. So how we tell our patients, cut back on your oral hypoglycemics if you're not eating and you're really sick for a couple of days, just to make sure we don't cause any problems. Same can be said with the SGLT2 inhibitors. If patients aren't eating and they're not hydrating, then maybe they should be holding off on these medications until they're starting to feel better. There's also pretty routine guideline advice to hold these agents around surgery. So again, around a time where patients won't be eating, or they'll be in more of a stress state where that can precipitate DKA. So based on the half-life of these drugs, holding them for about 3 days should put them out of the woods of developing a DKA. Also, if patients are getting really dehydrated, or if they're going on a bender, which hopefully they're not doing, but you can tell them to skip their empagliflozin that morning. The other thing would be to counsel patients on avoid omitting insulin, or how sometimes they're like, oh, this patient didn't eat, so we're not gonna give any insulin, but counseling against, keeping our basal insulin on board to help prevent precipitating DKA. Is there any questions about that, or does that all make sense? I know this is something that's newer to me that I'm trying to remember to make sure we educate patients about and spread some awareness, because I think it's something that we could probably manage pretty well if we do this. There's not a lot of data, but it seems to make sense if we just enact this kind of stuff. So my summary, basically for the SGLT2 inhibitors, is that I think they do reduce cardiovascular risk and mortality in type 2 diabetics especially with cardiovascular disease, specifically empagliflozin and canagliflozin. But these agents are certainly not benign, so we do need to kind of respect these agents. They do have some rare serious adverse events, and they also do have their common adverse events like genital infections. A practical tip, this isn't really shown in a lot of the studies, but it's always something that to think about with these agents, is that because of kind of the diuresis effect, especially when you start having patients who are on other diuretics or very sensitive to changes in volume, it's something to keep on your radar to monitor a little bit closely if you're starting one of these agents, to keep an eye on their volume status. But that's something that makes sense logically, but hasn't necessarily showed up in a lot of the trials, but something to also keep aware of. So here is my golden slide of this presentation of the answer to the first objective, which is which of these agents have been shown in randomized controlled trials to reduce cardiovascular events. So we've got our good old-fashioned metformin, and then we've got some newer kids on the block, the GLP-1 agonists, specifically in Canada, liraglutide, semaglutide, and dulaglutide, at this time only subcutaneously available, but semaglutide oral probably, I'm sure, will come down the pipeline soon. And then we've got our SGLT2 inhibitors, both oral drugs, oral daily drugs, canagliflozin and empagliflozin. So now probably what you're all wanting to know is so can we actually get our grubby little hands on these medications? So a lot of them, no, but some of them, yes. So first we'll start with what we have available in Interior Health on our hospital formulary. We all know metformin is a free-for-all. Oh man, Allison's in this room. Pressure's on. It was pretty straightforward. So thank you for also I bugged Allison a little bit to figure out the status on some of these things, so thank you for your help. So metformin is unrestricted. You can use it for any patients. The only one of the agents that we have on formulary that have the cardiovascular benefit other than metformin is empagliflozin, and it's currently restricted to patients who have type 2 diabetes and who have not been adequately controlled based on their A1C with metformin and a sulfonylurea. So that is currently the restriction criteria, but it is on formulary and it should be probably stocked in most hospitals now. Canagliflozin and dapagliflozin have been reviewed or looked at, and they're not going to be added to formulary, and none of the GLP-1s have been reviewed for formulary. And Allison requests that we don't go that route, so I'm just kidding. But they've not been reviewed, but they're not available for formulary. So this hospital formulary considerations are very much aligned with our PharmaCare formulary in terms of coverage from PharmaCare, so that makes it a little bit easier for us. So as we all know, metformin is an unrestricted benefit from PharmaCare, and the only drug that's available for coverage at this time through PharmaCare is empagliflozin, and you do have to fill out the special authority form, and the special authority requirements are the same as our hospital requirements, and they're not at target A1C on max metformin plus a sulfonylurea. So I'm not saying that's necessarily the therapeutic approach that we should take, but it's the therapeutic approach you might have to take if you have patients that need the coverage. And why do we make some of these decisions? Well, here's the cost information basically about these medications. So they are all costly medications. The SGLT2 inhibitors come at a little bit less expensive than the subcutaneous GLP-1 agonists. So the SGLT2s, both empagliflozin and canagliflozin, are sitting around $100 a month. And this is usually without markups or fees, so it's actually going to be a little bit higher for your patients. One thing that is interesting that's available on the market is there are some combination pills with the SGLT2s and metformin that actually cost almost the same price. So if patients have private plans that will cover the combo, then that's potentially an option for people. And then the SGLT2 inhibitors are still quite pricey at this time. They're all in the hundreds of dollars a month. So honestly, I think that's one of the big reasons that we haven't seen a huge uptake of these medications is that they're just very costly, no coverage provincially or in the hospital. So patients have to have a pretty good private plan in order for them to probably be on one of these medications. So let's bring it back to our case, our gentleman. So again, let's remember this 63-year-old guy who came into the cardiology service with an NSTEMI. He's got type 2 diabetes. His A1C is 8.2%. He's kind of on a max dose of metformin. And you're trying to decide, should I start another medication for this guy for reducing his cardiovascular risk, specific to his diabetes? So I'd like everyone to pick up their phones again. And this time you get to freehand whatever you want. Please no profanities. And let me know, what kind of things would you be talking about with your patient, practically? What kind of things are you going to discuss at the bedside to determine whether you're going to start one of these agents, and if you are, what one are you going to start? So I'll give everyone a couple minutes to do that. I still see some people typing, so I'll give them a second. They might be on Facebook, but who knows. All right, let's see what we got. Awesome. All right, so I'm seeing hypoglycemia history. So these patients, have they had hypoglycemia? Cost and coverage. Yeah, that's going to be a huge point. Third-party plans, adherence, drug coverage. We're going to look at, compare and contrast some of the potential side effects. Are they okay to do injections? So yeah, the route of administration is huge because a lot of people are resistant to insulin, and they're probably they might be resistant to GLP-1 agonists for that same reason. Can you afford it? I'm seeing that's a very common theme, and unfortunately, that is. Maybe we're going to get that universal pharmacare now. I don't know. That might make our jobs a lot easier, but we don't have to get political tonight. Do they have genital infections, or is that a big problem for them? Have they tried anything else? What are their goals regarding their health? I love that one. What are they looking for? Are they looking for pill burden? Are they looking for reducing cardiovascular events? Do they really want to live another 10 years? Or do they want to come back to the cardiology service and visit you again? That could be one thing. Have you had issues with DKA in the past? Great consideration. Are they actually compliant with their current medicine? I love that. Are they actually taking that metformin, or are they just giving you that look that they are? Have they tried any of these drugs before they had diabetes? Are you interested in talking about your diabetes control? I like that. Just coming at it just completely are you going to talk to me today? That's actually really good, because sometimes they might be overwhelmed because you just counseled them on their other 5 cardiovascular meds, and you might decide this is not the time. Maybe we're going to readdress this in another month, and that's also a very good point. Have you taken more lifestyle, food? What are your goals for the next 10 years? Compliance. Awesome. So thank you so much for all of that. That's really good discussion, and I hope I saw a lot of the good, every theme. Wait, Team Kamloops has even turned off Survivor for your present. Oh, I'm so happy. Thanks, guys. I know you have my back there. They got my joke. Yes. Okay. Yeah, again, thanks everyone so much for that discussion. I think that's all the points. Like, I don't have a take-home one-size-fits-all for you for all of your patients, but I hope you've kind of left that with like what kind of the idea of the magnitudes of benefit we're looking at. What are the drugs that are really your therapeutic alternatives? What are the side effects? What do you need to monitor? What do you need to talk to your patients about? And if you want some more light reading, there is also a lot more new trials that have recently been published in cardiology about these drugs. So the SGLT2 inhibitors are not going anywhere. Get really cozy with them, learn about them, because they are going to be around for a while. Some of you probably heard about the DAPA-HF trial that got published like a month ago about using dapagliflozin in heart failure. So now all of the other SGLT2 inhibitors are being looked at for both HFrEF and HFpEF. So we'll be seeing that coming down the pipeline. And then we've also we're still waiting on the ertugliflozin trial just to show the cardiovascular benefit or lack of benefit. And then the Credence trial also recently came out looking specifically at diabetic patients with kidney disease. It did show some positive outcomes on reducing kidney disease. So there's potentially going to be a lot of future applications for these medications. So, there's cardiology. There's always going to be new and exciting things, more trials. But maybe next year we'll be talking about SGLT2s and heart failure. We'll give it a little more time. So with that, I open it up for any questions or discussions or complaints or feelings. Yeah, Nicole.
Thank you very much, Shirley, for your presentation. I know this was the focus of your presentation on heart failure.
Okay.
But I guess I just was wondering, in your practice of cardiology, because this to me is super interesting, that the dapagliflozin study showed benefit independent of whether patients had diabetes or not.
Yes.
I'm just wondering if you guys have discussed this in your practice, because I can see this being very interesting.
We have journal club this twice already. So my pharmacy student journal clubbed it yesterday, and we talked about it as a cardiology group like about a week ago. So we have talked about it, and I think we will be using it for heart failure indications. There are some interesting things about the DAPA-HF trial, though. Like actually, there was very few euglycemic patients in that trial. They actually almost all, like 50% had diabetes, and then another like 25 to 30% were like pre-diabetic. So it's actually like a lot, like there was very few who were euglycemic, so that's kind of an interesting thing about it. But I think the uptake will be I think the uptake will definitely start happening. But I think the main limitation is like the drug coverage and stuff right now, and it'll be nice when we have like at least one more trial come out to show it. But given the secondary endpoints of all these other trials, like I'm assuming they're going to probably be positive too. But I think as a group, where we're most excited about the possibility is in the HFpEF trials. That would be really nice if we had something we could use for HFpEF. So we'll be awaiting some of those coming out. But I mean, sometimes we just like shake our heads though in heart failure because of, especially for like HFrEF, the number of drugs that we have that we've recently so we're just starting to incorporate some of these new agents, and then more keep coming at us. So I think the question now is like, which one do you go to, and like, should we be using them all together or not? Like that's where the questions are going to start coming.
I guess too in heart failure, because they can cause hypotension and can affect your ability to effectively diurese the patients, especially when they're acutely admitted to that hypertension.
Yeah, exactly. And kind of adding that on top of their diuretics and then titrating and managing with that together could totally add a whole nother level of complexity. Any other questions? Any questions on the line? No. Okay. All right, thanks everybody.
Thanks so much, Shaylee. The heart diabetes trials are coming out fast and furious right now, so it's really, really nice to have a solid summary like that. So just a couple of housekeeping items for getting your CEU credits for the event. I'm going to be emailing out some knowledge testing questions just based on the trial, and then it will also give you an opportunity to give some feedback on the presentation and the event itself. And once you complete that, you'll get an email that will include your CEUs for the event. So expect that in the next couple of days, and it will be out for 2 weeks. Okay, thanks so much for coming out tonight. I really appreciate it, guys.